intact and the reverse shoulder replacement. So let's come one by one. So this patient, you can see there is a massive cuff here, whole of the cuff is retracted to the mid-pivot level, and you can see what whole, you can see the humeral head from the subacromial space. It's like an irreparable cuff. So don't try to leave that, don't try to call it as like an irreparable cuff and go for reverse shoulder in all of these patients. Try for release. And what is that? Is your subacromial release and release of your capsular part. So once you release the subacromial capsular part, you can see you can mobilize this cuff towards the footpit, and at the end of the procedure you can repair it very nicely with the all-suture anchor or a peak anchor or metal anchor. So massive cuff here, mobilize it and try to reposition it over the anatomical location, and always try to repair it if possible. Repair with augmentation. And now we have a fresh augmentation coming in. We have biological augmentation there. I prefer biological augmentation. We have a very cheap biological tissue available. There is a biceps tendon. This patient, you can see, is a massive cuff here, and it was almost irreparable cuff here. And the cuff defect was in the anterior part. You can see here the whole of the from the subacromial space. You can see this part is glenoid. You can see this is the humeral head. The anterior part of the cuff, you can see this is the posterior part of the cuff which is coming towards the footprint. The anterior part of the cuff, you can see it's almost, you have a massive defect in the anterior part of the cuff. So what are the treatment options? So you can put your SCR, you can plan for your release. After release also, if you see there is some defect in the anterior part of the cuff, the next very important step is your augmentation with the bicep. And what we do normally we try to remove the bicep. You can see the biceps is here in the bicipital group. We have removed the biceps severely. It acts like a depressor, or it acts like a superior capsule for this particular shoulder. And once you remove the bicep, you repair it with the cuff tissue. So this is a very good local biological tissue available there in your shoulder, by which you can just repair it and you can augment it with your rotator cuff. And then this is the supraspinatus part, you can repair it with the biceps. And at the end of the procedure, you can see, you can augment it with the biceps SCR. So biceps SCR is a very good viable option for massive cuff tear where you have a defect in the anterior part of the cuff. Tendon transfer. Young patient. Nowadays we get a young patient with a massive cuff tear. So we have different tendon transfer options available there. The most oldest tendon transfer we have been doing for ages the lattice transfer, and that is for posterior superior defect. If you are defect in the posterior superior part of the cuff and loss of internal rotation, try to do LD transfer. The pectoralis major transfer is for your anterior defect. So if you are defect in the anterior part, you can plan for your pectoralis major transfer, and the lower trapezius when you have loss of external rotation. And nowadays we are moving towards the lower trapezius transfer, more and more towards the lower trapezius transfer, because lower trapezius is in line with the infraspinatus. The only issue with the lower trapezius is your tendinous part is very small. So you have to augment it either with your 70 graft or sometimes tendinous longer graft to get a good tendon length and cover the whole footprint of your rotator cuff area. In SS for massive cuff here, I think now it's available in India. Last 6 months we are using it. But what are the indications for this? You should have a very clear-cut indication. Then check for the intact force couple. And what is the force couple in the shoulder joint? Anteriorly you have subscapularis, you have infraspinatus. So if you have a subscapularis and infraspinatus intact, then you plan for in-space balance spacing. So this particular patient, you can see this is a massive cuff tear, irreparable cuff tear. This subscapularis and infraspinatus is intact. And once you put your scope inside, you can see this is a irreparable cuff tear. So if your force couple is intact, if you put your balloon, the synthetic balloon inside, it will just depress the humeral head and the deltoid gets a chance to fire, and you can rehab this patient with the rehabilitation of your subscapularis and infraspinatus. So you can see this is a synthetic balloon here. You just put it in the subacromial space, and once you inflate this balloon, you have to inflate it with a normal slide. Normal, we have three sizes of balloon available for this irreparable cuff here. The small, medium, and large. This is the medium size balloon that is for your almost 45 millimeter of the defect. And you can see once you inflate it, gradually this balloon is pushing your shoulder down. And as your shoulder comes down, your delta gets start fading, and that is the Monday you get for another 12 months. Because after 14 months, this is a biodegradable material, it degrades in the subaqueous space, and you can rehab your subscapularis, you can rehab your infraspinatus, and the patient can get full range of motion. And you can see after full intervention of this balloon, whole of your shoulder is coming down, and you can see almost it has come to the normal anatomical position. So, my dear friend, the indication for in spaces irreparable cuff tear with intact force couple, you should have an intact subspace and the infraspinatus. Patches. Now patches are coming in a big way. Yesterday we have a shoulder related we have discussion in the workshop also. So we have basically three types of patches available now in worldwide. The structural patches which gives strength, the biological patches which gives some amount of biological in there, and now we have a patches which is a combination of structural and biological tissue. The only thing these patches are they are very costly and we have very limited indication. Still we don't have long-term follow-up, more than 5-year long-term follow-up of using this patch. Reverse shoulder replacement. Yes. Some of the cuffs are irreparable and you can see there is a cuff arthropathy. These are the indications, these are the cases where you should not plan for your rotator cuff repair, you should not plan for your balloon implantation, you should not plan for your tendon transfer. So cuff arthropathy, yes, reverse shoulder replacement is the ideal treatment. In these patients, you can plan for reverse shoulder replacement. So this is a simple treatment around there. You can see a partial cuff here. Most of the time I rehab them and pain is not subsiding, you can just keep them on, you can put one or you can give 1 or 2 doses of steroids. Young patient, good cuff quality. Always repair and repair with augmentation in the treatment of choice. Young patient, poor cuff tissue, irreparable cuff. Don't go for reverse shoulder replacement. Go for tendon transfer. If you have a posterior defect, you have good tendon there, the lattice topside and your lower trapezius. If you are antral superior defect, you can go for pec laser transfer. Elderly patient, poor cuff tissue, irreparable cuff. And if your force couple is intact, then you can plan for your ciliary capsular reconstruction with the balloon implantation. So those are the indications for balloon implantation. And elderly patients, cuff arthropathy, these are the group of the patients where the most of the cuff is irreparable, you can plan for your reverse shoulder replacement. Thank you so much.
Thank you very much, Dr. Rajiv Raman, for your excellent lecture. Next, I'd like to call Professor Shah Alam, whose contribution in spine surgery in Bangladesh you all know, our smartest spine surgeon of the continent, evergreen, Dr. Shah Alam.
Good morning, ladies and gentlemen. Thank you for nice introduction. My topic in the state surgery is spinal deformity. So if I start with if I want to travel somewhere, if you see the very good quality bars and the very bad quality of bars, my question is that, and we ask anytime who is the driver or how much experience he has, or when we are planning to go somewhere by train, anytime did we ask anybody who is the train captain or driver who is taking it a long way? When you are going to ship, more or less safe, there's chance to go any accident. But anytime nobody asks who is the captain, how experienced he is. When you are planning for abroad, when the plane is crashing, 100% fatality, 100% patient will die. Even that, we ask anybody who is the pilot, how experienced this pilot, answer is no. So, when the question comes concerning the spine, and if it is the deformity correction, so many questions. Who is the surgeon? Is he a spine surgeon? Is he a neurosurgeon? What is his background? How experienced he is? How many surgeries he has done last year? So, the question arises about the experience, about the surgeons, how much surgery he has done, how much competition has been arising. and what would be the procedure, either open technique or MIS technique, or what would be the subsequent expected complications after surgery. Because patient wants the safety, because the safe surgery is the wanted or expected by the patient attendant. And when it comes to the spinal deformity, more questions arise. Because the spine helps to stand work, and if the spine is not okay, your upper limbs, lower limbs cannot work properly. That's why there's a lot of questions. So now comes to the question, what is the safe surgery? So as per the WHO, they recommend that the safe surgery refers to a set of lot of best practices. What is done to reduce the surgical risk, to reduce the complications, perioperative, post-operative, even the infection or any sort of morbidity or mortality. So these are the points that should be considered in the safe surgery. If we review the literature, the most important things for spine surgery is that the safety is the priority. So first is the safety, not the maximum correction, not the concern of the over correction or under correction, as because there are a lot of sophisticated instruments are available. If I am not oriented to that sort of the technique, then I cannot start that because I don't know what are possible complications. That's why what should be the protocol of the safe surgery. So first, safety is the surgeon safety. Second is patient safety. Third is the hospital safety. As because a lot of issues are there now, the medias are very important. They are all running after you. So the surgeon safety, considering how much the surgeon is mentally or psychologically or physically stable. What is the status, family balance, or the work balance? That's one of the important issues. How experience is with his team. These are the questions comes with surgeon safety. Perioperative, post-operative, immediate post-operative complications, there should be the concern. So the comprehensive evaluation of the patient by taking the history and the physical examination, patient having any comorbidity and expected comorbidity, these are the points. And the optimization, whole the spinal evaluation should be done before doing surgical correction. So the X, if the spine, the whole spine including the skull and pelvis is not screwed in